Good evening, everybody. So, I hope I'm audible. If there is any doubts, you can post it in the chat section. So, we will begin talking about the pain management. So, I hope I'm audible. If there is any doubts. So, talking about the pain in surgery. So, all the patients who are undergoing any surgery are going to have some or the other amount of pain. So, whenever you are going to, so whenever we saw that ERAS protocol, whenever we saw metabolic response to injury, we saw that pain is going to trigger sympathetic response. And it is going to cause adrenaline rush. So basically, for any smooth recovery of the patient, pain should always be controlled. So first you need to know what are the types of pain. So first is a nociceptive type of pain. It is because whenever there is going to be any injury to the tissue, whenever there is going to be trauma to the tissue, the trauma is itself going to stimulate the local nerve endings and local pain receptors, and it is always going to be proportional to the stimulus. So that is why we are going to favor laparoscopic surgery over open surgery, because in laparoscopic surgery, the trauma is going to be less, the pain is also going to be less, and because of less pain, less adrenaline rush, the patient is always going to be recovering early. How are you going to manage this nociceptive pain? Because there is going to be local inflammation, local activity, you are going to control the inflammation by giving NSAIDs and paracetamol. And then comes the opioid. So what is WHO pain ladder? We are going to talk about it shortly. Then comes another type of pain, which is a neuropathic type of pain. So whenever the nerves which carry the pain sensation are stimulated, they are going to cause a neuropathic type of pain, which is going to be along the dermatome or along the nerve ending. So it will be always a burning or shooting type of pain. What do you mean by allodynia? So in allodynia, a normal stimulus is perceived as pain. So whenever I'm going to touch a patient, the patient is going to wince in pain. So ideally it should not cause any type of pain to the patient. That is called as allodynia. And it is always poorly responsive to opioids, because the problem is with the nerves and it is not with the local tissue. So here you need to give something which is nerve calming effect, which are gabapentin, pregabalin, amitriptyline. So these are the drugs which are going to calm the nerves and reduce the impulses which are going to be sent. Then comes the sympathetic component of the pain, and sympathetic activation is going to take place after the tissue is going to be damaged, and it is because of swelling and temperature change. So as we discussed allodynia, a normal stimulus can also be perceived as the pain, and here it is predominantly seen in cases like PVD. In cases of PVD. So in cases of PVD, even you touch the feet of the patient is going to wince in the pain, and the treatment of choice for this type of pain is always going to be a lumbar sympathectomy. Then comes what is allodynia. So it is a central sensation. It is because a non-painful stimulus causes pain. And here you are going to give neuropathic agents. And what is hyperalgesia? So hyperalgesia is nothing but whenever a small painful stimulus is being applied. So you pinch the skin very small. There are few people who are very hypersensitive to pain. So whenever you are just going to give them a light pinch, they are going to wince as if they are falling from 10th floor building. So that is nothing but the pain threshold is reduced of the patient, or there is exaggerated pain stimulus to minor injuries. And for these patients, there is also a psychotic component. So ketamine plays a very useful role here. So what is an WHO pain ladder? So whenever the patient complains of pain, we are going to have a 4-step ladder to the patient. So what is first step ladder? The first step ladder consists of NSAIDs plus minus PCM. So paracetamol plus minus NSAIDs. When you can also add, yes, when it goes here, you can also add opioids. But these are the low level, or these are the low potential opioids like tramadol. Whenever this pain goes unbearable, you can add higher opioids like morphine or IV fentanyl. And these substances are very cautiously used. That is the reason you won't get fentanyl over the counter, but you can easily get tramadol over the counter. And even if the pain is not controlled by this, then you have to intervene the patient. Intervene the patient in sense of put epidural catheter, or you can give the local nerve blocks. So that is the WHO pain pathway. So non-opioid pain, yes, as we said, paracetamol, NSAID, or you can add adjuncts. In mild, you can give tramadol plus minus opioids. This third step of ladder, you are going to add fentanyl, and last step is going to be interventional management. So the WHO ladder is used in both directions. Whenever some patients have severe amount of pain, you can downgrade you can actually de-escalate you can say the drugs. But when the patient is going to have light amount of pain and then you don't know what is the severity, you are going to have a step up approach. So always remember, use NSAIDs with caution, because NSAIDs, these are COX inhibitors, they also reduce the supply to the kidneys. So NSAIDs are going to cause pre-renal AKI. Important MCQ which comes to your NEET PG as well. So it causes pre-renal AKI because it is going to cause afferent vasoconstriction, afferent arteriolar vasoconstriction. So it is going to cause afferently. So what can it cause? It can cause renal impairment. So in pre-existing CKD, you have to use in caution. Another drug which we talked about for renal impairment was contrast agents. So whenever the NSAIDs are going to be given, as you know that aspirin also is one of the NSAIDs which is used as a blood thinner. These NSAIDs are going to inhibit COX-1 enzyme, which can cause platelet dysfunction and it can increase the surgical bleeding. In cardiovascular, selective COX-2 inhibitors are used. That is the reason why we are going to use selective COX-2 cyclooxygenase 2 pathway inhibitors, as there is increased thrombotic risk when you are going to use these drugs. And also for gastroprotection, the NSAIDs can cause stress ulcerations. Hence, always and always you are going to give PPI along with NSAIDs. Whenever you are going to give NSAIDs to patient, always make sure that you cover it with PPI. So what are some other special agents which can be used for pain management? So one is the anti-estrogen tamoxifen. Where do we use this? So typically in the patients of cyclical mastalgia or the patient of fibroadenosis. So whenever the patient is going to have severe pain which is not controlled by NSAIDs, you can also add OC pills or anti-estrogen, or you can also add tamoxifen. It is going to do the hormonal modulation of the breast and reduce the pain. You can also give radiation therapy. The radiation therapy is going to cause local destruction of the nerves, and that is the reason the patient will have less pain. As we already talked about lumbar sympathectomy, you can do it in patients typically for PVD, for lower limb vascular diseases, and ketamine infusion is given to reduce the opioid doses. So whenever a patient is dependent on opioid for long, it has its own side effects. So to reduce these, you can add adjunct, which is ketamine. So basically there is a special branch in anesthesiology which is called as the pain management. So pain management branch is a specialty branch in anesthesia which deals with all these things. But as a surgeon, you should know what are the minimum important things. So now we are going to take up a case scenario. So whenever you are sleeping at your room, let's consider that you have passed your residency and now you are sleeping in your room and your junior calls you, sir, the patient is not looking comfortable, the patient is having tachycardia, the patient is saturation is dropping, or something related to the patient who we have just operated yesterday or day before yesterday. So how do you do a post-op monitoring for any patient? So there is a score called as a News 2 score. What score does it tell you? So basically this score is going to tell you when do you need to actually check the patient for, or you need to do investigation for the patient. So when are you supposed to do any investigations? When are you supposed to shift the patient to ICU? So this score is for the beginners. When you are going to go, when you are becoming senior, eventually you will get to know what are the problems. Eventually when you are becoming the senior personnel in the room, you are obviously going to have the idea of what pathophysiology the patient might be knowing. But in case you are new to this, you should know that which patient needs intervention. You should know that which patient needs to be admitted, which patient needs to be shifted to ICU, or which patient can be just conserved in the ward. So these are the things which you should be knowing. So what does this score contain? So basically what parameters do you monitor in the patient? You have to check in the score. So it is the respiratory rate, SpO2, BP, pulse rate, temperature and consciousness. And whenever a patient is going to require oxygen, any requirement of the oxygen is going to add 2 to the score. So why is it important? Because if we are going to see the table of the score, whenever there is going to be 0 score, so no changes post-operatively, then 12 hourly monitoring, whatever is going on to the patient is fine. In case the score rises to 4, it means that patient needs at least 6 hourly monitoring, because some parameters, either SpO2, either breathing rate, either BP, either heart rate has changed, and because of those reasons you need to monitor the patient 4 to 6 hourly. So you might be feeling that your senior sometime tells you on call that I want monitoring of this patient for every 4 hours. You think that he is giving you a tox. You think that, oh god, he is doing it purposely because he wants to disturb my sleep. It is not that, because in case something is bad with the patient, you can pick it up within less amount of time and you can save the life. So that is the reason where you need to do a constant monitoring. If the parameter, if the score is between 5 to 7, then that is the time when you need to shift the patient to at least a monitoring unit, because every 1 hourly the patient needs to be monitoring. So at least the HDU, wherein the patient will have a monitor attached, and when the score is more than 7, that is the time when the patient needs an active intervention, an emergency surgery, or at least something needs to be intervened very fast. So each point is given a score of 3. So respiratory rate score of 3. You don't need to go in the details. If you go on Google, you are going to get an app for news to scoring, and you have to enter the parameters and the score. It is going to give you a score ready-made in your hand. So it is not going to come to you in the exam. It is not going to come to you in the MCQs, but you should know what is important in that. So every parameter has a score of 3. So any one parameter, whatever is given in the table, so any one parameter with the single 3 scoring naturally gets into the criteria of 5 or more than 5. So what have they said? That yes, so see, 0 to 4 the score is low, you need to just keep the patient under routine monitoring. 5 to 6 is medium, you need to shift the patient to an hourly monitoring program, and more than 7 means that the patient needs some amount of investigations. So these are the things which you should be knowing, and it means that yes, it leads an emergency surgery response, and any deterioration or any score of 3 directly shifts your grade into grade B. So for example, let's consider that the overall score is coming normal, but one of the parameters, only the respiratory rate has rise and the score is 3. So that is the time when you have to do an early monitoring of the patient. So this score is given in Bailey Love. It is important for a clinical point of view. It might not be important for your MCQs, but this score is very highly clinically important. Then comes a system which is known as a Clavien-Dindo classification. So let's see first who is he. He's a Pierre Clavin. He's a surgeon in Switzerland. He's a HBP surgeon, and then he proposed the mechanism of the complications which a surgeon has. So you should know that how competent you are managing the patient, what are your post-operative outcomes, and how are you managing the patient. So basically, if you see what is grade 1, so grade 1 is some pathology which is deviation from the normal. So let's consider a patient went an operation for a laparotomy and the suture line was soaked. So you had to take out couple of sutures and do continuous dressing. So that is nothing but grade 1. It did not harm any patient. It did not change the operative course of the patient. It did not add to any intervention to the patient. It did not cause any what you can say, the physiological compromise to the patient. Just a single suture out because of some soakage. So simple wound opening. A patient might have post-op nausea, vomiting. So that comes in the score of 1. What is grade 2? So in grade 2, you require some pharmacological intervention along with the opening of the suture. If you start escalating IV antibiotic, if you give total parenteral nutrition to the patient, if you need to give albumin to heal the wound, that is the time when you are going to grade it as grade 2. What is grade 3 and what is grade 3A and grade 3B? In grade 3A, the patient requires an intervention. Let's consider the suture line got an abscess and that abscess was to be drained. So you took the patient to the OT, gave local anesthesia and drained the abscess. So any intervention done under the local anesthesia is 3A. But now there was the burst abdomen. The patient came with the burst abdomen. What is different between a suture gape and a burst abdomen? So a suture gape is nothing but only the skin and subcutaneous tissue opens. But when it is a burst abdomen, all the layers including the sheath or including the rectus sheath is also opened up. So that is the time when the patient needs intervention and rectus sheath cannot be closed locally. It requires an general anesthesia. So you return to the theater for this patient. So it means that the patient requires some amount of general anesthesia or a regional anesthesia by anesthesiologist. That is grade 3. What is grade 4 and grade 5? Grade 4 is a single organ failure. For example, a patient gets into AKI, a patient gets a pneumonia, patient gets arrhythmias, patient develops atrial fibrillation. That is the reason when one system is failed, it means that the patient is grade 4A, and grade 4B means multi-organ dysfunction syndrome. So 2 or more than 2 systems have started failing and it has causes threat to life. This is nothing but grade 4B, and grade 5 is nothing but, yes, it is the death of the patient. So these are the things which you should be knowing when you are answering the question, because this system is pretty much asked in all the papers. Might be UG, might be PG, might be entrance exams, it is asked. So Clavien-Dindo, it is an international standard for reporting the surgical complications. So whenever you attend large conferences, multinational conferences, these people are going to use this terminologies very routinely, that this patient had a uneventful course with Clavien-Dindo 0. If this patient had Clavien-Dindo 3, it means that you should have a click that this patient's course was, how did the patient course go post-operatively. Then we are coming down to some simple things. Post-operatively, each system, what complications can happen. So in respiratory system, there can be upper airway complication because of intubation. There might be some laryngeal edema, there might be some hematoma, and you have to secure the airway immediately. Atelectasis. Why is there an atelectasis? Typically, when you are going to operate in the subdiaphragmatic region, maybe for liver, for gallbladder, for spleen, there is going to be diaphragmatic irritation, and because of that diaphragmatic irritation, there is going to be secretion of fluid in the pleural cavity. So there is going to be secretion of the fluid in the pleural cavity, and also the diaphragm, because of pain, is not going to contract vigorously, and that is the reason the underlying lung is going to get collapsed. So how are you going to treat it? Obviously, to exercise the diaphragm, you are going to promote early mobilization of the patient, give him chest physiotherapy and spirometry. So it is very much important. Usually on day 3 and day 5, if this atelectasis continues, if you have not treated the atelectasis properly, the patient will develop post-operative cough and then develop fever. It is a simple thing that wherever the oxygen is reaching, there the lung is functional. Wherever the lung goes out of function, the development of the bacteria starts, and the bacteria is going to cause a pneumonia. So day 3 to day 5, the patient is going to develop pneumonia. Pulmonary edema, because you are not going to manage the patient properly. So when you are going to give excessive fluids to the patient, when the cardiac status is not achieved properly, there is going to be development of pulmonary edema. And what is post-operative respiratory failure? So whenever a patient requires persistent ventilation for over 48 hours post-operatively, in simple terms, after 48 hours, even if the patient requires some amount of respiratory support, may it be ventilator, may it be oxygen, it is considered to be a part of respiratory failure, and something is wrong with the patient and you need to check for it. So till 48 hours after surgery, even if the patient requires O2, it requires ventilator, we can consider it as a normal physiological response. After that, the patient should be weaned off from all the oxygen. It means that there is some pathology going on in the respiratory system. What can happen in cardiovascular system? So hypovolemia is the most common cause of hypotension. Also there can be cardiogenic shock to the patient. Also there can be septic shock. So you need to rule it out according. We have already seen shock. How are we going to check for the CVP? How are we going to manage the patient? We have already seen it. The septic shock requires antibiotics and vasopressor support. Cardiac requires inotropes, and hypovolemia requires fluid and blood resuscitation. Arrhythmia is the most common complication, which is the atrial fibrillation, and it might be because of pain, hypoxia, and electrolytes. So first you have to check what is going wrong, and then you are going to correct the atrial fibrillation. Hypertension. So always remember this clinical hint. Whenever there is a new onset hypertension, typically post-operatively. What I'm saying, whenever the patient develops hypertension, typically post-operatively, two main things you are going to check for before starting or before giving a medicine call is constipation and micturition problems. That is the retention. So this is the most common cause of hypertensive response post-operatively. So whenever you are going to operate a patient, always have a check on blood, always have a check on your bowel and bladder habitus, and if the patient has passed urine or not. So MI, most of the surgeries, there might be an MI in the post-operative period which goes unnoticedly and the patient might pass away. So anyway, anytime if you feel that patient is having chest pain, always go and get an ECG done. We already told you that minimum 4 metabolic equivalents are required. A normal resting state, a body requires one metabolic equivalent, that is 3.5 liter per kg per minute of oxygen to a muscle cell. But whenever you are going to operate any patient, that jumps to 4. And 4 metabolic equivalent means the heart is working constantly at least 3 to 4 times that of the normal. The preload is increased, the afterload is increased, and the circulation is increased. So always make sure that when a patient is having chest pain, don't just neglect it. Just check an ECG, and by ECG, if the patient is having MI, you can further manage it. You know the reason, because the body is running into a stress response and it is pumping the blood 4 times that of the normal. Then comes your renal failure. This is the medicine definitions. I'm not adding anything to it. So it is whenever there is a rise in the creat. So let's consider that the patient's creat is more than 1.5 baseline. It is class 1. More than 2 times creat is 2 or more than 2. It is the KDIGO stage 3. And whenever it is 3 or more than 3, it is considered to be KDIGO stage 4. Also, the urine output, as I said, minimum urine output monitoring should be 0.5 ml per kg per hour. So that basically 60 kg man per hour is urine output should be minimum of 30 ml. So minimum of 30 ml. If it is less than that, it means that the patient's kidneys are at toss. So you have to again rule out, is it a pre-renal AKI, is it a renal AKI or a post-renal AKI? There might be sometimes there might be clogging of the Foley's catheter. The Foley's catheter might be blocked. So everything needs to be checked properly. So whenever the urine output falls less than 0.5 ml per kg per hour for 6 hours or for 12 hours, it is stage 1 and stage 2 respectively. And if it falls more than less than 3 ml per kg, 0.3 ml per kg per hour or anuria, it is nothing but KDIGO stage 3. And whenever you are going to check for it, always keep a medicine consultant handby, and you might need the patient to switch to dialysis whenever these, at least for KDIGO stage 3, whenever you are having suspicion of it, always make sure that you have a standby medicine consultant on call, because that is the time the patient might require a dialysis later on. So urinary retention, if more than 3 hours, catheterize the patient. So normally any surgery which is less than 3 hours time, which you apprehend that the surgery would be less than 3 hours, you don't need to catheterize the patient. But if it is more than 3 hours, catheterize the patient intraoperatively. And for AKI, adequate hydration is important. And nephrotoxic agents like NSAIDs, aminoglycosides and contrast, use it cautiously. So again, talking about it, contrast and aminoglycosides cause renal AKI. And NSAIDs are going to cause pre-renal AKI. Pre-renal AKI. Then one more short table from the Bailey Love. Patients might develop post-operative delirium. What is delirium? The patient starts to talk something which is not normal. The patient goes into trance and the patient is not able to actually, apprehend the normal human behavior. So there are 2 types of post-operative delirium. One is hypoactive disorder or hyperactive disorder. So hyperactive disorder, always one thing to be considered is it is seen in alcoholics or addiction patients. That is the whole reason we need to abstain the alcohol and tobacco at least for 6 weeks prior to surgery, or else no elective surgery. No elective surgery unless and until the patient is abstinence at least for 6 weeks, because the patient might develop hyperactive post-operative delirium, wherein the patient is agitated, confused, and patient might be like there are more disruptive risks. The patient might have risk of falls, and typically seen in patient of post-opioid or alcohol withdrawal. And hypoactive disorders are predominantly seen in the patients of hypothyroidism, old age patients, because they have the higher mortality risk. These patients can actually be bedridden for a long period of time. So that is the reason you should have a thorough mental examination before taking any patient for the OT. At least when you know that the patient is alcoholic or the patient is of too much age, like more than 75, more than 80, that is the time you should check for a mental examination too. What can be the causes? What can be the organic causes of these things? So it can be renal failure, respiratory hypoxia, Addisonian crisis. I told you an example yesterday. A patient not recovering from hypotension at all. This patient was on over-the-counter steroids. So that was the time we actually checked her drugs and we started with the steroids again. So Addisonian crisis. There might be hepatic encephalopathy, hypoglycemia. So these are the reasons which can be correctable. And within fraction of seconds, the patient is going to recover. So always look for any organic cause before labeling the patient as post-operative delirium, and reorient the patient, bring the familiar faces in front of the patient. Patient should be always in the lighted room. If you keep the patient in the dark room for long, the patient has more prone of developing or is more prone for developing this post-operative delirium, and haloperidol is the last resort. So after doing all these managements, the patient is still violent, the patient is still traumatic, the patient is not listening, the patient is pulling out his Foley, is pulling out his drain, then that is the time the only drug to be given in this patient is haloperidol. It has shortest duration of action and it is less side effects, so you can give haloperidol to the patients. So now coming down to the post-operative fever. So a very important note in this factor is these are not die-hard rules. So any patient can develop fever any time of the after any type of the operating recovery, and the cause might be anything from these reasons. These are just the observations from many patients who were studied, and from them ideal ideal systems were ruled out. The first day of the fever might be related to the lungs, the third day of the fever might be related to your vascular system, seventh day might be related to the local causes. So that was an average estimation of everything, but it is not a die-hard rule that this day means this system is involved. So what are the basic things? So immediately post-operative, we saw that the patient develops atelectasis. The patient might have pleural effusion, and that is the reason the patient develops fever. Here you don't need to do anything. A chest X-ray is enough, and start him on incentive spirometry. Day 1 to day 3, there might be pneumonia. Because you have not taken care about that atelectasis, now the patient might have pneumonia and chest infection, or the patient might have urinary tract infection because of Foley's catheterization. That is the reason I told you Foley's no more than 3 hours. So if patient has surgery more than 3 hours, then only Foley's, or if the surgery is less than 3 hours, no need to catheterize the patient. Urine culture, sputum culture, and chest X-ray is important. Day 3 and day 5, because the patient has not mobilized, you did not apply ERAS protocols properly, the patient was not mobilized, and that is the reason patient might have developed a DVT, especially patients of malignancies. Especially the patients of malignancies, the patient might have developed DVT, and here you need to first check the limb if there is an edema, is there any tenderness, and then you need to get a Doppler sound or consider a D-dimer. 5 to 7 days, there might be wound infection, anastomotic leak or collection. So till day 7, you cannot know if your anastomosis is actually healed or not. On day 1, day 2, day 3, day 4, the anastomosis might be working good because of the sutures, the tensile strength of the sutures. But because of those bowel enzymes, the sutures start getting eroded and the actual healing starts. So till day 7, you cannot 100% make sure if the anastomosis is healed or not. And anytime the fever might come anytime during DVT, hematoma or atelectasis, and always just don't give antibiotics, treat the cause. And after day 7, there can be any cause. It can be because of anastomotic breakdown, it can be because of secondary hemorrhage, it can be because of pelvic abscess. So you need to check what is the actual cause of fever. So correlate everything clinically. How the radiologists tell you on the reports, correlate clinically. So correlate what the patient is having. Is the patient having tachypnea? Is the patient having tachycardia? Is the patient having abdominal distension? So you can actually find the cause of fever. Fever and tachycardia are the two main important things which a surgeon should always check during his rounds. You need not check BP every time by your own, but at least a hand on the pulse is going to give you an idea if the patient is having tachycardia and the patient is having fever. So a tachycardia which is not settling down even after 48 hours, 72 hours, even after adequate pain management, it means that the patient is having some amount of problem and some recovery is getting hampered. So what is the enhanced recovery protocol? A single table, ERAS protocol, a short note in your surgery papers, and some MCQs in your NEET PG exams. So what is ERAS protocol? So the ERAS protocol is divided into 3 components. The first component is the pre-op component. The second component is the intra-op component, and the third component is the post-op component. So what is the pre-op component about? So pre-op component is when you are going to give carbohydrate loading. So what is the mechanism of carbohydrate loading? We already saw that when the patient is going to undergo surgery, the patient is going to be in the hyperglycemic, or the patient's body is trying to become in a hyperglycemic state because brain needs more amount of glucose. The fats are going to be broken down. The insulin resistance is going to increase, and to counter that insulin resistance, to tell the body that don't worry, we have ample amount of sugar, so you load the patient before operation with carbohydrate drink. He can take it orally 2 hours pre-op with clear water, and that is going to cause hyperglycemia in the patient. And when you are going to put an incision, that trauma, the body will understand, okay, we have a lot of sugar, I don't need to go into a hyperglycemic state, and I don't need to release glucagon. So because of that, the patient's post-operative recovery will be fine. The patient will not lose much amount of proteins and fats. So it reduces the insulin resistance and improves the post-operative muscle function. Then the patient should be ideally kept nilper out only for 6 hours, not for 8 or 10 hours or overnight. So whenever you are planning for surgery at 6 a.m., NBM from 12 p.m. Whenever you are planning surgery at 10 a.m., the patient can have his last meal at till 4 a.m. So make sure that the patient is having meal till last 6 hours, because it is going to again reduce these carbohydrate related problems. And 2 hours for clear fluids. So clear fluids means, yes, the clear fluids means the carbohydrate drink which you are going to give. And this is going to it is going to reduce the aspiration risk, but also not cause any dehydration to the patient. Then preoperative mechanical bowel preparation. So they told that avoid mechanical bowel preparation because in elective surgery they found that it is not much of benefit. What happens is, actually while you are preparing the bowel, even the good microbial flora which is required gets washed away. And after getting washed away, when you are going to do anastomosis, the later on the healing process, the villi formation will take long. So it is not a routine practice to do a bowel preparation in the Western countries. We still do it in the Indian countries because we know that the patient comes from a patient might be from a lower socio-economic class, and then the patient infection will be very difficult to tackle later on. What is to be done intraoperatively? So intraoperatively, as I said, patient's body is going to release ADH. We already saw it in the first chapter. In metabolic response to injury, the ADH is going to be secreted, and that ADH is going to cause water retention. So you don't need to give excess water. So goal-directed fluid therapy. Don't overload with water. The body is secreting ADH. If the body retains a lot of amount of water, then the anastomosis or the bowel anastomosis which you are going to make, there is going to be edema and it is not going to heal properly. So no excess water, and the patient should be normothermia, because as I said that all the clotting mechanisms, all the enzymes in the body require normal pH and normal temperature. So maintain normothermia and the patient's all the enzymes will be working fine. If a surgery goes on for 10 hours to 12 hours and the patient becomes hypothermic, you will find out that the patient starts bleeding more, because the coagulation factors require a lot of enzymes, and these enzymes need to be normothermic to actually act in their normal physiological range. And if you are going to promote hypothermia in the patient, then these enzymes will go for a toss, and that is the reason the patient will be having a lot of bleeding. So you should take care that these things don't happen. What after post-operatively you are going to do? So early mobilization of the patient, because you are going to early mobilize, the muscle receptors are going to be refreshened, the insulin resistance is going to decrease, and also the protein breakdown will decrease. If your body thinks that, oh, this thigh muscle is of not use anymore, so it is going to break down the thigh muscle and get the proteins in the blood. Early enteral nutrition. So a very beautiful sentence told by one of my seniors: whenever you are going to do a bowel anastomosis and you are going to tell the patient you are not going to have anything for 7 days, is that anastomosis going to be dry? Obviously not, because whenever you are going to do an anastomosis, normal contents, 1 liter of the contents from stomach, 500 ml from gallbladder, 500 ml from pancreas, and 500 ml itself from the small intestine are going to pass. So almost 2.5 liters of fluid is going to pass from that anastomosis, whether you are going to keep the patient NBM or not. So at least when you are going to give food, or at least you are going to give some liquids to the patient, those very harmful juices, what I'm saying, those juices are very strong. So those will be diluted, and they will actually be used for what they need to be used for. So early enteral nutrition is always favored in patients, and analgesia is multimodal. As I said, opioid is a double-edged sword. If you are going to give opioid to the patient is going to have ileus. But if the patient is going to have pain, still he is going to have ileus. So what are you going to do? You can actually go for epidural. You can actually go for epidural. You can go for TAB block, transversus abdominis preperitoneal block. So they can act locally and reduce the pain. So these are the things. And early removal of drain and catheters, because these are the source of infections. A catheter which is placed for more than 2 days itself acts as a source of infection, a urinary tract infection. The drains can have ascending infections, and it also promotes mobility. So ERAS reduces, these are the studies which they have done, ERAS reduces hospital stay by 30 to 50%, reduces the complications and reduces the cost. So no complications. We saw Clavien-Dindo classifications. So no complications, less burden on the patient, less burden on the hospital, early patient coming, early patient going discharge, less stress on every system. And it is typically seen with patients of HBP, urological and gynecological surgeries. So colorectal, HBP, urology and gynecological surgeries. So we don't need to fear that much. We can use the ERAS protocols and enhance the recovery of the patient. So now coming down to the last chapter of today's discussion, this is going to be a little bit of big chapter, but very important when it comes to your surgery papers and also for your NEET PG exams and NEET SS definitely. So what is perioperative nutrition? Perioperative nutrition. So whenever you are operating a patient, one important thing we checked before was a CPET. So what was CPET? Yes, we check the patient for cardiopulmonary exercise testing. Is the patient's condition good? Can the patient's heart, lungs and his physiology handle the surgery? And now comes the second part, which is the nutrition. So if the nutrition of the patient is going to be adequate, you can take the patient for surgeries. So two requirements for doing major surgeries. One is CPT testing, another is a good nutrition. So whenever these two things are going to come to the patient, then you are going to start the patient or then you can do surgery to the patient. So after prolonged fasting, the glucose stores the glycogen stores are first exhausted, and gluconeogenesis starts from the proteins, and that is the reason we are going to load the patient with carbohydrates before surgery. That is the reason why before running marathon, these people drink the Glucon-D sachets. Why? Because it gives instant energy. Glucose is going to give instant energy. Glucose is required for the brain as well as for the muscles. So if glucose is given to the patient, naturally the patient's protein catabolism is going to be reduced. So dextrose or DNS in fasting patients has a significant protein sparing effect. So always remember, even after operating the patient, make sure that you are giving glucose to the patient, or else the patient will have a lot of catabolism. And brain glucose requirement is minimum 2 gram per kg per day. Hence 45% of the energy of your daily meals come from carbohydrates. That is the reason when you might have checked that keto diet and those stuff which were quite like fantasizing stuff previously. What used to happen is, because of those keto diet, the brain's metabolism used to switch from glucose to ketone bodies. And hence the person who used to do the keto diet used to sleep during the daytime. He was not active during the daytime, or he was not as active as a normal person would be. He was not as enthusiastic. Why? Because the brain shifts the metabolism from glucose to ketone bodies if you are in the prolonged starvation. But glucose is required for faster metabolism, 36 ATPs, and the brain is going to function like anything. So what are the requirements? Again, factual things, just try to include it in the notes. So normal energy requirement is 30 kilocal per kg lean body weight per day. So 30 calories per kg per day is the normal requirement of any any person. So how much does this increase? So normally if you see 1.5 times more requirement is seen in patients of 1.5 times more the requirement goes after a surgery. 2 times more in patients of burns and sepsis. Because the body is having lot of metabolism, so this energy requirement is going to jump 1.5 to 2 times in a patients who are undergoing operation or burns. So protein requirement, again, we are so much hypoproteinemic. 1.5 gram protein per kg per day. So we don't have this much amount of proteins. One egg usually hardly contains 6 gram of protein. So if you are a 50 kg man, your daily protein requirement is around 75 grams per day protein you should have. And that is the reason 20% of the total energy should come from proteins. And then comes the carbohydrates. It is mostly important for the brain. Again, remember 2 gram per kg per day requirement of carbohydrate. And it has the protein sparing effect. Fat, remainder 35%. Fat plus glucose in combination reduces the complications and optimizes CO2 and fluid balance. You know that whenever the carbohydrate metabolism is going to happen, whenever the lipid metabolism is going to happen, the end substrate after an aerobic metabolism is always going to be CO2. So CO2 is going to be liberated along with ATP, and that CO2 is excreted from your respiratory system. So hence the fat and carbohydrate together in conjugation are going to have the protein sparing effect. Sodium requirement 1 millimole per kg per day, potassium 1 millimole per kg per day. Vitamin C is definitely required, which you don't give supplementation. So that is the reason that all post-operative patients should have vitamin C, because when you are going to have a laparotomy patient, whenever a bowel anastomosis patient is going to be there, the healing is going to occur by collagen formation, and it is essential for collagen synthesis and wound healing. So all the patients should get IV vitamin C, and later on the patient might be shifted to oral vitamin C. B12, normal supplementation is not necessary, but if the patient is going to have gastric, what I'm saying is that if the patient is going to have gastric or an ileal resection, so if the patient is going to have ileal resection or gastric resection, that is the time you are going to give the patient B12 supplementations right after the surgery. And albumin, so what happens in many institutes is you do an albumin levels post-operatively. Any albumin level done post-operatively is going to be low, because albumin is going to be diluted. Albumin is a negative acute phase reactant. What do you mean by acute phase reactants? So the proteins which are going to increase in the body in cases of inflammation. So what are the acute phase reactants? We know the C-reactive proteins. We know the procalcitonin proteins. So these proteins are going to increase when the patient is in the stress or inflammatory state. But albumin is a negative acute phase reactant. It is going to contract and it is going to reduce in the patients who are having post-operative state of inflammation. So albumin is the marker which is important for pre-operative assessment. it is not much of use in post-operative surveillance. So always remember, a post-operative patient is going to have hypoalbuminemia. That does not mean that you should supplement the patient with albumin immediately. See the other parameters of malnutrition, which I'm going to tell you. See the edema, if the patient is developing an edema, if the patient is in volume overload, if the patient is having some problems related to the protein metabolism, then only it is the time to supplement albumin. Or else routine albumin supplementations, just because the albumin levels are low, are not at all justified. So only replace if the patient is having hepatic failure or ascitic losses, not a nutritional marker, and albumin infusion has no nutritional benefit otherwise. So I hope it is crystal clear to you. So it is not a routine requirement of transfusing patient with albumin. So let's come down to a tool which was developed previously to assess the patient's nutrition status. There are many tools, but this one is given in Bailey and Love. So 3 components are to be checked. One is the BMI of the patient. So one checks the physical parameter of the patient, that is BMI. The second important thing is clinical parameter, which is a weight loss. And if the patient is acutely ill, or even some people consider using albumin here, preoperative albumin. So normal albumin is more than 3.5. So few people are going to consider using albumin preoperatively as a marker in the MUST tool. So whenever the score is going to be, we are going to check for if only one parameter is present, if 2 parameters are present, if 3 parameters are present, or no parameters are present. So no parameters, low risk. 1 parameter, it is moderate risk, and 2 out of 3 of the parameters are present, it means high risk. So it means that you need to refer the patient to a nutritionist. And you should get a detailed diet plan, optimize the patient, and then operate. A moderate risk is same as low risk, but here you can give oral supplementations, and in low risk patient you can take the patient for surgery straight away. So this is nothing but MUST tool. What is MUST tool? Malnutrition Universal Screening Tool. So MUST tool is given in Bailey and Love for checking the pre-operative nutrition. So what are the 3 components? One is the physical parameter, one is the history related parameter, and one is either you can take it clinical or a biochemical parameter. So what is that? BMI, unexplained weight loss, and the third important parameter is yes, albumin. So as you can see, BMI score 0, 1, 2, then unplanned weight loss less than 5%, 5 to 10%, more than 10%. So total scores calculation, if any score 1, even score of 1 is present, patient needs optimization. And if score is more than 2, then that is the time the patient is to be subjected for a nutritional support before operating this patient on. So now we are going to talk about the nutrition to the patient. So many of the people belong from Maharashtra, I believe, and we follow the concept called as Navratri. So when you consider Navratri, so our parents or our grandparents, or sometimes if we also believe in those concepts, even us, they don't have even water for 10 days. What did I say? Hardly. Some people only drink water. They don't even have any type of food for those 9 days, but still they survive. So how is the mechanism? So that's what is given in Bailey Love. So any human body can survive up to 10 to 12 days without nutrition. Obviously, I am talking about survival. It does not mean that the patient might be physiologically normal, but till 10 days, even if the patient is not able to have any type of nutrition, it is fine. The patient is going to survive. But if the patient needs to be NBM for more than 10 days, that is the time the patient is going to require a nutritional support. So what chart we are going to make right now is, yes, how are we going to classify what type of nutritional support is to be given to the patients? So first ask the question, NBM more than 10 days. So if the answer is yes or the answer is no. So if the answer is yes, then comes our down flow chart. If no, then you can actually start the enteral feed slowly and you can start the patient to wean off from NBM. That is fine. But if the answer comes yes, then we are going to ask a question, okay, now I need to supplement the patient. So is the patient's enteral use, can the patients be given enterally? So where are the conditions where you cannot give the patient enterally? If there is going to be a large bowel resection, so large bowel as in not the large colon, so the large segment of the bowel is resected, and you cannot give the patient enteral nutrition. That is one cause. That is the short bowel syndrome. What is another cause? The patient is in prolonged ileus. So in cases where the GI tract cannot be used, so that is the time. So if the enteral nutrition can be given, then what is to be done? And if enteral nutrition cannot be given, so the answer is here. Here you are going to go for a parenteral nutrition. So here you are going to go for parenteral nutrition. So parenteral nutrition. Again, based on the duration, if nutrition is going to be required only for less than 7 days. So let's consider for 10 days you are going to pull the patient, but you require, oh no, I cannot give the patient enterally till now. At least for next 5 to 7 days, I need to pull the patient for his nutrition. So that is the time you can give PPN, which is partial parenteral nutrition or peripheral parenteral nutrition. The osmolarity is less, 700 milliosmoles, and that is the reason you can give this nutrition from peripheral line. You don't need to put a central line for this reason. But the nutrition, if it is going to be required for more than 7 days, that is the time you are going to switch the patient to total parenteral nutrition. You need to switch the patient to TPN, total parenteral nutrition. But this is all when the GI tract cannot be used. But if the GI tract can be used, then again same answer. For how many days are you requiring nutrition? Less than 10 days or more than 10 days? So if the gastric emptying is going to be good, again for less than 10 days, if the gastric emptying is good, then you can straight away put a Ryle's tube. You can put a Ryle's tube. But if the gastric emptying is not going to be good, then you are going to put a nasojejunal tube. Nasojejunal tube. But if you are going to require nutrition more than 10 days, then again ask the question, the same thing, gastric emptying. So good, go for a feeding gastrostomy. But if gastric emptying is poor, then you might need to consider a feeding jejunostomy. You need to consider a feeding jejunostomy. So this table, if you are going to put it on your exam, then it is going to give you full marks. So surgical nutrition is a long answer question. So whatever things we have talked about, a must tool, then we are going to check for the patient's nutrition post-operatively. So this is the table which is going to help you to score marks in your exam. So let's get back. So what is the thing? Yes, so we are going to talk about the each routes. Now we know which route is to be used for which person. So what is that? If we are using a Ryle's tube, start initially after inserting a Ryle's tube. You know that the Ryle's tube length is taken from the tip of the nose till the tragus to the xiphisternum. So that is the length of the tube which should be inside. So that mark, it might be 55, it might be 60 centimeters. So that at that mark you are going to fix the Ryle's tube at the nose. So initially start at 12 ml per hour. Why? Because if the gastric emptying is poor, the patient might vomit out and aspirate. So slowly increase up to 75 ml per hour over 48 hours. So initially start with 20 ml per hour and then escalate to 75 ml per hour. So Indian Jugaad again, who is going to keep on giving every hourly? So we give 200 ml per 2 hours. First give 50 ml of test feed. Clear water is given for first 50 ml, then clamp the Ryle's tube, see for an hour or so, re-aspirate the Ryle's tube. If nothing comes out, you can start the patient with feeds. 200 ml, 2 hourly is the routine dose which we give in the Indian settings. Then if the patient is requires the nutrition for more than 10 days, the Ryle's tube is cumbersome. It can cause infections, the pharyngeal infections, it can cause aspiration, it can cause pneumonia. So, and because of those tubes, the patient will have irritation in the nose, there will be hypertrophy of the nasal ala, the hypertrophy of the concha, recurrent sinusitis, frontal headaches. So RT for 10 days is more than enough. If the patient requires nutrition for more than 10 days, then that is the time you are going to do a endoscopic, what do you call it as a peg. It is not the peg of alcohol. This peg is nothing but per oral endoscopic gastrostomy. So with the help of an endoscope, you are going to put in a gastrostomy tube. And here you know that irrespectively the tube is not in the nose or in the throat. So if the patient is going to aspirate, the patient is going to vomit out. Whenever the patient feels like vomiting, he's going to vomit out. So it won't cause aspiration. So you can start the full feeds from day 1 itself. It is the gold standard for long-term enteral feeding. So these are the things which you know. Everything is related to this table. So if you know this table well-heartedly, you don't need to have to worry. Sir, if the endoscopic route is not feasible, the patient is having some laryngeal cancer, upper esophageal cancer, so I cannot do an endoscopy, then one thing is you can do a surgical gastrostomy. Just put an incision, open the abdomen, and then put the gastrostomy tube, or you can do it laparoscopically. But again, it requires anesthesia, it requires lots of problem. So that is the reason you are not going to, do it routinely. And now comes the role of interventional radiologist, that is radiologically image guided gastrostomy. So what happens is, few patients have very narrow esophagus. So an RT can pass through it, but an endoscope cannot. So what can you do is, in those scenarios, you can inflate the stomach with air. So when the stomach is inflated with air, it is going to touch the anterior abdominal wall. So whenever the stomach is going to touch the anterior, so this is your anterior abdominal wall, this is going to be the stomach lumen. So whenever this lumen is touching the anterior abdominal wall, with the help of fluoroscopy guided X-ray imaging, you can straight away puncture the stomach from the subcutaneous region or from the skin. So that is nothing but surgical gastrostomy. That is nothing but radiologically image guided gastrostomy. So NG tube is inflated and then the gastrostomy is inserted under X-ray where endoscopy is not feasible. And if the patient's gastric emptying is going to be poor, it is going to be a jejunostomy. But mind you, jejunostomy, the lumen of the jejunum is thin as compared to the stomach, and in prolonged diseases, there is always going to be a perijejunostomy leak. So this is going to be our jejunum. So the jejunum is going to erode because of the enzymes. These there are going to be peritubal erosions, and there is going to be formation of a fistula. So from the sides of those jejunostomy site, there is going to be leakage of bowel content. So jejunostomy is cumbersome. So always prefer a gastrostomy wherever possible. So again, as I said, start enteral feed. So whenever you are starting an enteral feed to the patient, start with approximately 1.2 kilocal per ml with 0.06 gram of protein. Again, factual questions, the people who are toppers will remember it or else leave it off. Protein formulas are available for catabolic states, because we saw that when the patient goes into catabolism, muscle starts getting wasted. So to prevent muscle wasting, we are going to start this. And starting the position will be start from less. Give less amount of fluids, because the patient might have a refeeding syndrome, which we are going to talk about it shortly. Then comes the parenteral nutrition. When the gut is not functional, there is ileus, bowel obstruction or cereal malabsorption or an enterocutaneous fistula, you are going to administer the total parenteral nutrition. So that is a 3 liter all-in-one bag which contains around 150 to 200 kilocalories per liter. So total of 600 kilocalories, which consists of glucose, amino acids and lipid emulsions. So if you have seen the bag of parenteral nutrition, this is the bag. So one contains amino acids, one contains this contains lipids, and one contains carbohydrates. So these are separated initially. So what you are doing is this man is peeling he's pushing the fluids, and it is going to get mixed all together and going to form a semi-solid white colored, a thick liquid which is going to be white colored, and you're going to transfuse the patient for over 48 hours. So this total parenteral nutrition is usually transfused for over 48 hours to the patient. So what you are going to do when you are going to, it is a normal phenomena that whatever you are going to eat, the body is going to absorb whatever is required and rest throw it off. But in parenteral nutrition, you are forcing the contents and nutrients to get into the blood, but the electrolytes might be deranged. There might be problem with the vitamins, micronutrients. So to have a control over all these things, what things need to be checked? This is an MCQ. So daily you are going to check the patient for glucose and electrolytes. Why LFTs? Because these parenteral nutrition get metabolized in the liver. It can cause cholestasis. And that cholestasis is dreadful. The patient might develop into cholangitis and patient might die. So that is the reason, because the patient is not eating by mouth, the bile flow is restricted, and because of restriction of the bile flow, the bile gets stagnated. So that is the cause of cholestatic jaundice in those patients. What are you going to monitor weekly is the B12 levels, coagulation factors, zinc and copper. And every 3 to 6 months, there are patients who might require parenteral nutrition for lifelong. Patients of short bowel syndrome, the patients whose bowel has been cut because of mesenteric ischemia, anemia, a large amount of bowel is cut, the patient cannot have anything orally. So in US and UK, they have these centers called as parenteral nutrition centers. The patient comes 1 in 3 days, he has a central line inserted or a chemo port inserted, and from that the parenteral nutrition is given to him for maybe 7 to 8 hours, and the patient goes back home. So these are the centers in outside country. Here it is not feasible because of our economical constraints, but these are the things. So whenever the patient is going to be given parenteral nutrition, every 3 to 6 months you are going to check the patient's vitamin D3 levels, selenium levels, and bone profile, because the patient might have lacking calcium, the patient might have small micronutrient deficiencies. So these are the things which you should be checking. Sir, TPN, I am giving it to the patient, it is very nice, I am managing the patient, but it comes along with complications. So what are the complications? So the complications are broadly divided into 2 components. The complications of TPN can be divided into metabolic and line related. So TPN always requires a central line. So what can happen? Line related infection. The line is inserted, a subclavian line or an internal IJV line is inserted, it can cause a pneumothorax. And what are the metabolic complications? The first important metabolic complication on which there is always going to be an MCQ, at least in your surgery or in your pediatrics or in your exams, that is the refeeding syndrome. So what is refeeding syndrome? I'll try to explain it in simple terms. Another important factor is there is going to be cholestasis. So hepatitis induced by total parenteral nutrition. So what are the line related complications? Line related sepsis, pneumothorax, or air embolism because there might be arterial puncture. The refeeding syndrome is because of hypophosphatemia. I'll get down to it later. And there can be hyperglycemia because you are giving glucose, there might be some insulin resistance, there might be some problems. So insulin resistance might be required, insulin infusion might be required. Another metabolic is hypertriglyceridemia because you are continuously infusing the fatty acids. There might be development of hypertriglyceridemia, which might predispose patient to stroke or pancreatitis. So reduce the lipid infusion rate. So there are different compositions of parenteral nutrition available, wherein the normal composition of parenteral nutrition, which is 40 30 30, it might be 50 20 30. So the lipid component might be reduced. So you can get those mixtures as well. Those cost around 7,000 to 10,000 rupees. So it is quite difficult to manage such patients. You need to have a lot of check on them. And IAFLD. What is IFLAD? So it is intestinal failure associated liver disease because of TPN. So fatty liver is developed, and especially in the children, and whenever these changes are starting, try to transition to enteral nutrition as soon as possible, or you can consider a small bowel transplant. So you should know it. So sir, what is refeeding syndrome? So what happens is when the body is in persistent state of fasting or catabolism, all the electrolytes of the body get depleted. Potassium, phosphate, then magnesium. So all these electrolytes are depleted. So all the electrolytes come from the cells into the blood. So if you are going to check the blood potassium, it is going to be normal or just a lower normal limit, but actually the cells are lacking the potassium, the cells are lacking the magnesium. So whenever you are going to infuse the patient with TPN, what happens is because of entry of glucose, there is sudden insulin rise in the body. So that insulin rise is going to go and activate all the cells. Okay, we are having lots of nutrients, open your door. So cells are also going to take potassium along with them, magnesium along with them, and phosphate along with them. So why is phosphate required? Phosphate is required for ATP generation. It is adenosine triphosphate. So phosphate is an important component of ATP, and that is the reason all the phosphate, magnesium, and the potassium is going to go into the cell, and the patient develops complications like seizures, tetany, sudden onset delirium, sudden onset nausea, vomiting, sudden onset cardiac arrhythmias. And because of all these things, the patient develops a syndrome which is characteristically involving all these systems called as a refeeding syndrome. Sir, why have they considered phosphate as the hallmark? Because the patient might have hypokalemia because of other reasons. Dehydration, loss in the stools, the patient might be having loss in the urine, but phosphate and iron is very specific for refeeding syndrome. So whenever a patient is in refeeding syndrome and you take the blood levels of phosphate, those are going to be inherently less. So always remember that for that, initiate the fluid at a slow level. So what have they said as refeeding syndrome? In critically malnourished patients, sudden shift of phosphate, potassium and magnesium intracellularly and profound hypophosphatemia happens, which causes cardiac arrhythmias, respiratory failure, confusion and seizures. So start slow and go slow is the take home point from this. And replace the electrolytes before actually starting TPN. So let's consider one small thing, which is a small bowel syndrome, and then we can stop for the day. So what is short bowel syndrome? When the functioning of the intestine, the length of the intestine is less than 100 centimeters, it is a short bowel syndrome. Always remember that ileum is irreplaceable. So one sentence to take home from short bowel syndrome is ileum is irreplaceable. Ileum is irreplaceable. So you cut the jejunum, ileum will take the function of jejunum, but vice versa is not possible. So if you are going to cut the ileum, the jejunum will never take function of jejunum. So what happens is the bile acids are absorbed in the ileum. That is the one complication, and bile acids are highly irritant and it can cause bile acid diarrhea. And another important thing is B12 absorption happens in the ileum. So whenever you are going to resect ileum of the patient, make sure that you give the patient B12 supplementations and not orally, always intramuscularly or intravenously, because if you give those supplementations orally, it is not going to be absorbed. So always remember, an ileal resected patient needs B12 supplementation for lifelong, and for this bile irritant bile salts, what do? We give a drug called as a cholestyramine. We give the drug called as cholestyramine. So that is tackleable. Now comes the jejunal resection. It is better because whatever is absorbed in jejunum, the ileum can take over the function. Typically talking about the fatty acids and your folic acid. Bile loss. So if the ileum loss is more than 100 cc, bile acid is lost, which causes steatorrhea. So in these cases, you are going to limit the dietary fat intake of the patients. And adaptation method is usually the intestine requires 2 years to be adapted. So now you are going to take off the jejunum from the patient, and you expect that ileum should do the work of jejunum within 2 days. It's not possible. So the time span for taking up of the function of jejunum is going to be 2 years. 2 years. And high output short bowel syndrome is more than 4 liters per day. So what is short bowel syndrome? I'll just draw a chart and tell you. And always remember that if you are going to give hypotonic fluids to the patient, it is going to worsen the output. So always use isotonic. Never recommend a patient to drink simple water. These short bowel syndrome patients become thirsty because they are dehydrated. So always tell them, whenever you are going to drink any water, always make sure that you drink the ORS water and not the simple water, because those are going to pull off the electrolytes along with them and going to add fuel to the fire. So avoid free water to this patient. So that is very much important. So let's consider drawing a chart of short bowel syndrome. So there are 3 types of short bowel syndromes. The type 1 short bowel syndrome is where the distal part of the jejunum, ileum and colon might also be resected. So what happens is, this is your stomach, this is the patient's stomach, this is going to be the beginning, this is going to be the duodenum, and this is going to be beginning of the jejunum, and this jejunum is out on the skin as the stoma. So only this is going to be the part for which the food is going to be absorbed, and here there might be resection till the right hemicolon, and that from there the patient might be having large bowel. So here this is going to be the worst outcome, because whatever the patient is going to drink from the stomach, within 20 minutes all the content comes out on the skin through the stoma. Within 20 minutes. So that's what they said, more than 4 liters per day if the output is coming, it means that the patient is having high output stoma, or the patient is naturally having a short bowel syndrome. So this is the most deadly type of short bowel syndrome, and patients require permanent TPN. And also this patient land up frequently into dyselectrolytemia and AKI, and persistent dyselectrolytemia and AKI. The second type is where the ileum is resected, and the jejunum is being anastomosed. So this is the duodenum, this is the jejunum, and the jejunum is directly anastomosed with the colon. So in this case also, whenever you are going to close the stoma and you are going to make an anastomosis with the colon, what happens is over 2 years of time, the colon is slowly going to take up the function of jejunum. The colon will also start to develop villi. The nature is great. It is going to support the body by developing the defense mechanism, and to combat this, the colon will also slowly and steadily start taking the function of small intestine. So the colon also is going to take the function of small intestine. So this is nothing but type 2 short bowel syndrome. Here the patient is going to require TPN support up till 2 years. But later on the patient might recover. There are high chances that the patient will recover. So if you know that type 1 short bowel syndrome, if it is not getting treated with TPN, or the patient is landing into frequent AKI, patient is landing into the dyselectrolytemia, the treatment of choice here can be actually going for jejunocolic anastomosis with cover of TPN. So you should know that when the patient's type 1 is done with anastomosis, it is going to convert into type 2 fistula. And in type 3, there is going to be only small loss of segment of ileum or jejunum. So there is going to be intact small bowel. So type 3 is what routinely we do. There is going to be small resection of the where there is going to be resection of the jejunum and ileum, and they are going to be anastomosed with each another. So that is the type 3. So here it is going to be jejuno-ileal anastomosis. And this is going to have the best prognosis. So this is going to have the best prognosis. So that's all for the short bowel syndrome. The same thing they have given, that whenever the adaptation period is going to be 2 years, the adaptation period, if it is 2 years, you should give that time. Until then you can supplement the TPN. In high output states, avoid giving isotonic fluids. That's it. So B12, typically post gastrectomy and post ileal resection. This is a very important chart. After operating the patient, you should know that which supplements need to be given to the patient. So B12 typically for post gastrectomy and post ileal bypass. Bile acids are to be given if the patient's bile acid sequestrants are to be given if the ileal resection is more than 100 centimeters. And the patient will also be having, because the patient is going to have steatorrhea, patient will also have fat soluble vitamin deficiency. D3, because of total long-term TPN, there is not going to be adequate D3 in the patient, so the patient might develop osteomalacia and bone mineral disease. And also manganese deficiency in long-term TPN, and MRI will show that there are going to be toxic deposits in the basal ganglia. So these are few things, facts which are given. Vitamin C is important for post-surgical wound healing, always remember. And zinc is very important, typically to be given in patients of diarrhea and large losses of the fluid from the stoma. So that's all. I hope it is clear. And here we come down to the end of the chapter of perioperative care, and from here onwards the interesting topics are going to start, that is the trauma. And from tomorrow we'll start off with the trauma, and typically we're starting off with the trauma principles and primary survey. I'll share the PDF with you tomorrow in the group before starting. So till then, revise whatever you want. The lectures are there on the YouTube, so whenever you have the link also in the group, so you can just check it off and you can revise how much ever you want to. Okay, till then, take care, good night and bye bye. If you have any doubts, just let me know on the WhatsApp.